Welcome and thank you so much for joining us today for a webinar introducing what really represents a revolutionary advancement in non-invasive prenatal screening, Prequel with AMPLIFY technology. The focus of our webinar is to share how fetal fraction amplification addresses the limitations of currently available NIPS offerings and how this innovation can ensure that you are providing equity and care to all of your prenatal patients. My name is Susan Hancock. I'm the Clinical Product Manager for the Prequel Prenatal Screen here at Myriad Women's Health, a genetic counselor by training, and will be your moderator for today's event. I am pleased and honored to be joined by two of our experts, Dr. Dale Muzzey and Dr. Jim Goldberg. Dr. Dale Muzzey is Vice President of Bioinformatics here at Myriad Women's Health. He's an expert in genomics technology and was a key contributor in the development of Prequel with AMPLIFY. He received his PhD in biochemistry and biophysics from Harvard University. Dr. Jim Goldberg is the Chief Medical Officer at Myriad Women's Health. He's board certified in obstetrics and gynecology, maternal fetal medicine, and medical genetics. Before joining Myriad Women's Health, he served as president of the Perinatal Quality Foundation and was on the board of the Society for Maternal Fetal Medicine. Our presentation today will be divided into three sections. First, Dr. Goldberg will speak briefly about the implications of low fetal fraction and how it results in disparities in pregnancy care today. Second, Dr. Muzzey will detail how fetal fraction amplification addresses limitations of NIPS at low fetal fraction. Third, Dr. Goldberg will discuss how fetal fraction amplification in turn enables equity in care across all patients. We'll then finish with a Q&A. We will be accepting questions and comments through the chat feature and will address as many as possible if we have time. And any that we don't have time for will be forwarded to our speakers after the webinar for follow-up via email. With that, I'll turn it over to our first speaker, Dr. Goldberg.
Thank you, Susan. As most of you know, NIPS has been a major advance in aneuploidy screening due to its increased accuracy and its decreased false positive testing rate. Unfortunately, one of the limitations of NIPS has been the finding of a low fetal fraction in some patients who undergo testing. Many investigators and professional organizations have looked at this. Find a low fetal fraction is a fetal fraction of less than 4%. A low fetal fraction can be caused by several factors. It's been associated with a high maternal BMI, also with earlier gestational age. In addition, certain aneuploidies, specifically trisomy 13 and 18, have been associated with a low fetal fraction. We think that is because of reduced placental mass. Unfortunately, those aneuploidies are ones that we're screening for, so it can make the detection in patients with low fetal fraction much more challenging. In terms of looking at high BMI, as we all know, many patients who present to our practices have a high BMI. When this has been looked at, about 50% of pregnant patients actually present as overweight or obese to their OBGYN with a BMI greater than 25. Another problem with this is that BMI is not evenly distributed across ethnicities. As you can see from the chart on the right, the percent of women who present with an increased BMI can range from over 50% in the Native American population to less than 10% in the East Asian population. Current strategies to manage patients with a high BMI include maternal serum screening or offering NIPS later in a patient's pregnancy. We'll talk more about these approaches in just a minute. But all of these types of special approaches to deal with this create a disparity in care. This is an algorithm that looks at strategies that have been suggested by investigators and professional organizations to potentially deal with patients who might have a low fetal fraction. The algorithm, as you can see, is quite complicated, and I don't intend to go through each of the boxes on it, but I want you to get a sense of the complexity of these various approaches. And I'm sure you understand that this also creates significant workflow disruptions in your practice in trying to deal with these patients. If you look at the main three approaches, which we mentioned in the previous slide, either delaying NIPS or maternal serum screening, you can see that all of these lead to, most commonly, a delay in NIPS results. And this will lead to increased patient anxiety while they're waiting for their results, or the result being available later in pregnancy, which may decrease their pregnancy options. Other approaches also have been devised, but all of them essentially will create challenges in terms of changing the workflow to the patient and in your office workflows. A recent review by Lisa Hoy and Diana Bianchi in Prenatal Diagnosis have addressed the issue of low fetal fraction samples. What they say in the review is that, and I quote, "Addressing the problem of low fetal fraction is a high priority. Many approaches have been proposed to enrich fetal fraction by optimizing sequencing conditions, capitalizing on the biological differences between fetal and maternal DNA, developing new statistical algorithms." Well, we have, I think, risen to the challenge of trying to solve this problem, and I'd like to, in the next section, turn this over to Dale Muzzey, who will talk about the science behind our solution to the problem of low fetal fraction. Thank you. Dale?
Thanks, Jim. I just want to visually review some of the impact and drivers of low fetal fraction in NIPS. So most samples have high fetal fraction, where high is anything above 4%. So that's where you see all the blue dots there in the middle. And these samples with high fetal fraction get confident results on NIPS from our laboratory and any laboratory. The more challenging part, though, are the samples with low fetal fraction. So this is the minority of samples that have below 4%, but it's a not insignificant minority. Around 5% of samples have low fetal fraction and often receive a test failure on many NIPS platforms. So the drivers of fetal fraction that are important are shown above. Jim mentioned these. It includes BMI, gestational age, and aneuploidy. So the aneuploidy of a sample, for instance, if it's T13 or T18, is often associated with a lower fetal fraction. The gestational age is an upward force in fetal fraction. So as the pregnancy proceeds, fetal fraction increases, though this is a relatively minor effect, usually increasing fetal fraction less than 1% per week. BMI is a major driver of fetal fraction, and women with high BMI tend to have lower fetal fractions and enriched test failures on NIPS. We've explored these drivers of low fetal fraction recently in the clinical literature. We published 2 papers near the end of last year. One on the left in prenatal diagnosis looked at the efficacy of Prequel in women with high BMI. And the one on the right was a clinical experience paper of ours where we looked across the fetal fraction spectrum in nearly 60,000 patients tested with Prequel and found comparable results at high and low fetal fraction. Now, we've explored this very deeply, but we also know that there remains a lot of anxiety about low fetal fraction samples. And we're always striving to improve Prequel, and we do not want it to be a source of anxiety for anyone. And so we are extremely excited to discuss a recent technological advancement we've made that should really put to rest the concerns around low fetal fraction samples. I'm very excited to talk today about the content of our validation paper. This is undergoing peer review currently and is available as a preprint online. In our validation study and the verification study that preceded it, we tested more than 2,400 samples with our new technology and with our original technology. In this plot, we're showing the outcome with the original technology. So we're calling that standard NIPS. And we're plotting the fetal fraction on the x-axis and the BMI on the y-axis. So you can see where all of those 2,400 points landed. The average fetal fraction is around 10%. You see that there aren't many samples that are above 25% fetal fraction. And similarly, you can see that where that 4% cutoff is for what is a low fetal fraction sample. And there are samples that are below 4%. It's about 5% of the total samples, or around 1 in 20 women have a low fetal fraction. So again, this is our testing with just standard NIPS. So now I want to show you what happens when we apply our new AMPLIFY technology to this same set of samples. Okay, so now we're showing the same results with AMPLIFY. So these same 2,400 samples were tested with standard NIPS in one flow and with AMPLIFY in the other flow. We're still showing the standard NIPS in gray, and the AMPLIFY results are shown with the pink triangles. And you can see that each sample is linked. It was tested on both platforms. And critically, there is just a substantial rightward shift in the AMPLIFY workflow. So fetal fraction has gone up in nearly all of those samples, and it's gone up to a substantial degree. Let's focus on one of the samples just to orient to this plot. You can see up near the top. Up near the top there is a sample where the patient had a BMI of 51, and her original fetal fraction, and the fetal fraction she would receive on a standard NIPS protocol, was 2.4%. On many platforms, this would yield a test failure. However, with AMPLIFY, that sample gets transformed prior to sequencing into having an 8% fetal fraction. It's as if it came in the door with now 8%. And at 8%, you get very, very confident results on NIPS. So this is a patient who may have had a test failure or less confident results that now with AMPLIFY has highly confident results. And you can see that it doesn't just apply to this one patient. There's another one highlighted that has 2.3% that goes up to 11.3%. Another went from 2.8% to 9.9%. The critical thing here is no samples that we have yet tested within the AMPLIFY workflow have a fetal fraction less than 4%. None of them have low fetal fraction anymore with AMPLIFY. And it's not just the 3 samples that we highlighted that increased. You can see that that entire cloud of samples has shifted rightward to higher fetal fraction levels. We want to demonstrate that this is not just some bioinformatics trickery or like some weird math that we're doing to get this gain in fetal fraction. And to demonstrate that, we looked at very, very raw data in this next plot. So in particular, we looked at the number of fragments sequenced from chromosome Y in male fetus pregnancies. So again, there's very little bioinformatics polishing that has happened here. This is really just very raw data, and you can see that the same effect is observed. With the standard NIPS, there are fewer chromosome Y fragments sequenced. That's why the gray cloud is effectively to the left. However, upon applying the AMPLIFY workflow to those same samples, the number of fragments that we sequenced of chromosome Y in those samples is higher. And so that's why you see all of the purple triangles shifted to the right. So this is not like we just multiplied the fetal fraction by 2 or did some other type of trick in silico. This is a molecular transformation of these samples such that they now have substantially higher fetal fraction. So I hope that we've now shown that fetal fraction dramatically increases and increases in nearly every sample. This is a technology we apply to every sample tested with Prequel. But you may now be wondering, well, how does it work? Like, what are you actually doing? I hope we've established that we didn't just do some trick of math, but we did something molecular, but like, what was it? So let's look more deeply at that now. In this schematic, we show how AMPLIFY works, and it really leverages differences in the cell-free DNA length. So you can see in the diagram shown here that we are plotting the cell-free DNA length on the x-axis and the number of molecules that have that particular length on the y-axis. Maternal cell-free DNA is shown in green. So on average, most maternal cell-free DNA has a length of around 160 nucleotides. That's sort of the peak of that green triangle. Some fragments have a longer length, but there are fewer of them. That's why the triangle goes down. And some other fragments are shorter than 160, and that's sort of the left side of the green triangle. Now, the maternal cell-free DNA is more abundant than the fetal cell-free DNA, which is shown as the blue triangle. Also, you can observe here that the blue triangle is a little bit leftward shifted. And indeed, cell-free DNA from the fetus has been observed in many studies to be systematically shorter than the maternal cell-free DNA. So a standard NIPS workflow gathers all of this cell-free DNA and sequences a subset of it. And so when you gather all of the cell-free DNA in the blue and green triangles together, the fetal fraction is basically the area of the blue triangle divided by the total, or so the area of blue divided by blue plus green. And in this case, that's around 15%. What we're doing with AMPLIFY is focusing on a particular region of the size distribution. So rather than sequencing all of the DNA of any size, we particularly select DNA of a certain length. And so that's shown in the pink demarcated region there. By doing this, we retain the fetal cell-free DNA in blue, but we do not retain a lot of the maternal cell-free DNA that's to the right of the pink region. And what happens is that now when you look at your fetal fraction, it is the blue triangle divided by the total area in the pink region, which is smaller than it was over on the left in gray. And so you have the same amount of cell-free DNA from the fetus divided by a smaller total, and that boosts the fetal fraction. So whereas the fetal fraction had been 15%, when you apply the size selection of AMPLIFY, now the fetal fraction in that sample is 35%. So now that we've seen how AMPLIFY works, let's look a little bit more closely at its performance. So I mentioned before that we apply this to all samples. And you saw in that previous plot that the pink cloud of triangles moves substantially to the right. But the question is, well, how much does it move? And how uniformly does it move? And that's what this plot captures. So what we're showing are those same approximately 2,400 points from the previous plot, but we're looking at their original fetal fraction with standard NIPS on the x-axis, and then the multiplier in fetal fraction that they receive upon undergoing AMPLIFY. So if there were no change in the fetal fraction with AMPLIFY, all of those dots would be at 1x. Anything above the line in the pink region shows that the fetal fraction increased with AMPLIFY. And if it decreased with AMPLIFY, it would be in that white region at the bottom. Clearly, nearly all of the mass in this plot is above the line. And so that means that nearly every sample increased, and indeed 99.8% of samples that we have tested increased their fetal fraction with AMPLIFY. The extent of that increase on average is 2.3x. You can also see that there is a kind of a curved shape to this plot. And indeed, the highest gain in fetal fraction is applied to the samples where you need it most. So samples that come in the door with less than 4% fetal fraction have a nearly 3.9x average gain in fetal fraction with AMPLIFY. And so that's what we saw in the previous slide with the woman at BMI of 51. Her fetal fraction went up nearly fourfold, and that's what you're seeing in this plot. Another thing to focus on here, for those 0.2% that had lower fetal fraction, nearly all of them started out with very high fetal fraction. Off toward the right of the plot, you can see, for instance, a sample that came in the door around 34% fetal fraction. After undergoing AMPLIFY, it may have been at 33%. That's fine because a sample with 33% fetal fraction has more than enough DNA to get a confident result. The key thing that you see is that there is an absence of data points at like near 0x. Like we just have not seen that samples undergoing AMPLIFY, whether they are aneuploid, euploid, or whatever, they simply don't have a dramatic decrease in fetal fraction. So to summarize, again, we see in nearly 100% of samples a more than twofold gain in fetal fraction. You get the highest gain on the lowest fetal fraction samples, and there are really no samples for which we see a substantial loss with AMPLIFY. So we've established that AMPLIFY increases fetal fraction and how it does it, but let's really now take a deeper dive into how it impacts the aneuploidy calling performance of the test. So in our validation study, we tested samples that were positive for T21, T18, T13, rare autosomal aneuploidies, microdeletions, and sex chromosome aneuploidies. Those are each of the tracks that you see here in the plot. So I've established with some of the figures that we've already looked at that the fetal fraction increases with AMPLIFY, and we've shown you how that happens. But what you probably really want to see is how this impacts the aneuploidy calling performance of the test. With a whole genome-based test like Prequel, we use a z-score to identify aneuploidy. Samples that have a z-score above 3, and there's that vertical line around 3, those samples are called positive, and samples that are below that threshold are called negative. You can see from this plot that we have tested in our validation study many screen-negative samples at the top, but then we've also tested many screen-positive samples for each of the different regions interrogated by Prequel, including T21, T18, and T13, the rare autosomal aneuploidies, microdeletions, and sex chromosome aneuploidies. Our validation study included many, many samples that were positive, so you can see that there's a lot of samples that are above that threshold around 3. The gray circle shows the z-score that those samples had when they were tested with the standard NIPS workflow, and the connected pink triangle shows the z-score after testing with AMPLIFY. And you can see that, once again, everything has shifted to the right. The samples that they remain positive, we got all of the positive calls correct, and the z-score was higher. So these are more significant, higher confidence calls. And that applied across the board of everything that we interrogated on the panel. Similarly, and very importantly, screen negative samples basically stay in that same place. They remain negative. And so ultimately what results is now you have screen negative samples with z-scores in the same place they were before, and screen positive samples with higher z-scores. The higher separation between negative z-scores and positive z-scores means that the sensitivity and specificity of the test are higher. The performance of the test is better. So one sample that might stick out visually when you look at this slide is in the microdeletion section. So there's a sample that has the gray circle that is called negative because it's below the threshold, and then the pink triangle is above the threshold, suggesting that it's positive. And so this is a sample that was included in our validation. It was part of our historical cohort that had screened on standard NIPS and actually was screen negative, but upon undergoing AMPLIFY, it now screened positive for a microdeletion. This is actually one of the main benefits that AMPLIFY will confer. Like microdeletions, which are classically extremely difficult to call on any NIPS platform, will be easier to call with AMPLIFY due to their boosted fetal fraction. So let's look more closely at that microdeletion sample. What we're plotting here on the left is the data from standard NIPS, and on the right is the data from Prequel with AMPLIFY. The x-axis is the chromosomal coordinate, so the position on the 5p chromosome arm. And the y-axis is the copy number that we're observing, or the depth of cell-free DNA fragments that we're sequencing. And so a microdeletion should look like a drop in that depth from 2. And you can see that in the standard NIPS plot, the kind of highlighted region in blue, there's really not a conspicuous drop. There's nothing there that would cause us to issue a positive call for this microdeletion. However, on the right, with AMPLIFY, there is clearly a downward shift. It is localized to a 3 megabase region. This is actually a very small microdeletion on par with the size of 22q, and it's really on the small end for a 5p microdeletion. We indicate with the arrow at the bottom where the typical breakpoint is around 15 megabases. This one is only 3 megabases long. Though we don't have diagnostic confirmation of this particular sample, we did run it multiple times with new extractions from the original cell-free DNA, and it repeated very consistently. So this is a highly reproducible result, and really shows a lot of the power of AMPLIFY. It can take something that is not visible on standard NIPS and make it visible and callable by the algorithm, and then ultimately make its way to patient reports. We've shown that aneuploidy calling performance with AMPLIFY increases, but let's now just summarize that numerically. So in this table, we're showing the analytical sensitivity and specificity of the test for common aneuploidies like T21, T18, and T13, rare autosomal aneuploidies in aggregate, and then microdeletions. And we especially call out DeGeorge syndrome. So you can see that for 22q DeGeorge syndrome, the analytical sensitivity that we find now with AMPLIFY is about 95.6%. So this is far higher than what it is on a standard NIPS workflow, where that's typically in the range of 60 to 70%. And it's now among the highest reported for any NIPS with AMPLIFY. I do want to stress that these are analytical sensitivity and specificity values, so they do not capture known and universal discordances in NIPS like confined placental mosaicism. Rather than look at these as sensitivity and specificity values, we wanted to reframe it in terms of the number of false negatives and low fetal fraction samples you would expect to see without AMPLIFY and with AMPLIFY. So in the top row, you can see that patients with low fetal fraction below 4%, that's around 1 in 20 samples without AMPLIFY. And that is less than 1 in 1,000 samples with AMPLIFY. We have yet to see a sample below 4%. So this is more than a 50x improvement there with AMPLIFY. Next, if you look at the number of false negatives per sample screened, the numbers were already quite low on Prequel without AMPLIFY. However, they are substantially lower with AMPLIFY. So the improvement to the tune of nearly 50x on the whole chromosome aneuploidies and nearly 10x on the microdeletions. Again, this is an analytical assessment, but it is nevertheless a dramatic improvement in NIPS. We now like to look at the impact of AMPLIFY on sex calling. So there are two main causes of sex miscalls. They're either technical in origin or biological in origin. The biological miscalls would be caused by things like confined placental mosaicism, whereas the technical ones are due more to a borderline fetal fraction. And we really can't, and nor can really any other lab, do anything about the biological causes, but the technical ones with AMPLIFY we should be able to effectively eliminate. So let's now look at our validation data to see what that gain looked like. So here's the sex calling data from our validation study. On the x-axis, we are plotting the fetal fraction as measured from chromosome Y. So it's effectively the number of chromosome Y fragments that got sequenced. And we're showing that in standard NIPS at the top and Prequel with AMPLIFY in the bottom. And you can see that there are two clear different distributions. There's one centered near 0, shown in green. That is the female distribution because they do not have chromosome Y fragments. And then there's the blue distribution, which is the males, and those clearly have chromosome Y fragments that got sequenced. And the main difference between standard NIPS and the one with AMPLIFY in the bottom is just that the number of chromosome Y fragments increased with AMPLIFY. So that's why the blue distribution is rightward shifted in the bottom. And the reason that this improves sex calling accuracy can really be seen with the help of this orange arrow. So that orange arrow is a sample that was included in our validation study. It was tested both on standard NIPS and AMPLIFY. And with standard NIPS, you can see that it's like right at the cusp between these two distributions. And it has a slightly higher probability of coming from the female distribution, therefore it was called a female fetus. In AMPLIFY, however, when we tested that same sample, you can see that the orange arrow is now shifted right, and it is far more likely to come from the blue distribution than from the green. So this would be a very strong male fetus call. We have diagnostic outcome on this sample, and it is indeed a male fetus. So this is a really good demonstration of like what would have been a technical miscall in standard NIPS because it was really on the border between the two, that now that the distributions of male and female are so much further separated by AMPLIFY, there just isn't that same border between the two. And these types of samples now fall much more confidently in either the male or the female distribution and receive the appropriate sex call.
Thank you so much, Dale. Now let's go back to Dr. Goldberg, who's going to talk a bit about how this enables equity and care across all patients. Dr. Goldberg?
Thank you, Susan. In the next few slides, I'd like to review how the advances Dale has described can impact clinical care. In this slide, you can see on the left a representation of the algorithm we spoke about earlier, outlining how patients who may be at risk for low fetal fraction, for example, patients with high BMI, the complicated workflow that they need to go through. Commonly with these patients, this leads to a delay in results. And in essentially all cases where that happens, patient anxiety goes up. So by being able to decrease the time to result, we can decrease anxiety. Also, by delaying patient results, in some instances, we reduce or eliminate certain clinical options. For example, a patient with a positive result who may opt for an invasive procedure, if the result is delayed, they may not be in a gestational age window to take advantage of a chorionic villus sampling. In these challenging times with the advent of the COVID-19 pandemic, it's also important to think about ways of minimizing patient anxiety and also minimizing the times that the patient needs to meet with her practitioner or needs to have an additional blood draw. Also, patients frequently, when they visit with their practitioners, aren't able to have their partner with them, and this also leads to increased anxiety. Being able to have patients get a reliable result the first time is more important than ever now. And because AMPLIFY can provide an accurate result in virtually all patients, that helps reduce face-to-face exposure by requiring fewer redraws or diagnostic procedures after a test failure. This makes the patients and providers safer. The Society of Maternal Fetal Medicine has recognized this and has issued the guidance on the left, which speaks to patients should be offered the option of NIPS instead of nuchal translucency screening to reduce patient visits. Now with AMPLIFY, all patients, even those with a high BMI, can take advantage of this. In addition, payers have also changed their policy. For example, Aetna now will cover reimbursement for NIPS in average risk patients. Just to review what Dale has already gone through, that AMPLIFY really provides equity now in care across all patients. AMPLIFY essentially eliminates low fetal fraction samples. It provides more accurate performance, especially for those with the greatest need, like those with a high BMI and specific aneuploidies that are associated with a low fetal fraction. For high BMI patients, there is no longer a need to delay testing or perform maternal serum screening instead of NIPS, or deal with increased test failure rates that lead to redraws and unnecessary invasive procedures. You can rely on an accurate NIPS result to manage all patient types. AMPLIFY is not only going to be helpful in those patients with a low fetal fraction due to BMI. It will increase the fetal fraction in all patients and will lead to higher sensitivity for the microdeletion syndromes like the 22q deletion, which means more confidence in these results for patients and providers. Also, there will be increased resolution, which will open the door to more accurate calling of novel deletions and duplications throughout the genome. Myriad Women's Health has had a long-standing commitment to creating equity in care in prenatal genetics. We introduced our expanded carrier screening because ethnic-specific screening guidelines miss a significant number of at-risk couples who are at increased risk for serious inherited conditions. We wanted to ensure that patients across ethnicities would benefit from early insights into their reproductive options. In a similar way now with Prequel, AMPLIFY technology also ensures all patients receive accurate results regardless of BMI and ethnicity, since BMI is not evenly distributed across ethnicities. I want to thank you for your attention. I'm now going to turn things back to Susan for Q&A. Thank you.
Thank you to both of our speakers today. At this time, we're going to review a select few questions. So for the audience, if you haven't done so already, go ahead, use the chat feature to send in questions. We are going to try to address as many as possible today, but we'll also be able to follow up with additional answers. Okay, our first question is a timely one. The question reads, a new ACOG practice bulletin on NIPS was released last week. Is AMPLIFY an acceptable approach to NIPS given this statement?
Thank you for the question. Yes, it is, and this bulletin highlights why fetal fraction amplification is actually so important, and I'll explain. First, it is exciting to see that ACOG SMFM has released this recommendation to offer prenatal genetic screening, including NIPS, to all pregnant patients. This has been a long time coming and will create access to more accurate screening for many more patients. The bulletin points out that cell-free DNA is the most sensitive and specific screening method for common aneuploidies. As you've seen in this presentation, Prequel with AMPLIFY further increases sensitivity and specificity compared to standard NIPS. This ACOG SMFM update also talks specifically about the challenges of low fetal fraction leading to test failure. As NIPS expands to a broader population, it becomes even more important to use a test that can provide a highly accurate, reliable result the first time across all patient types. Prequel with AMPLIFY technology essentially eliminates low fetal fraction samples. So it addresses this challenge head-on and ensures that NIPS can deliver equity and care across all patients as it is used more broadly.
So looks like our next question is for you, Dale. Will the amplification be applied to all samples or only those with low fetal fraction?
So fetal fraction amplification is now routinely applied to all Prequel samples. So there's no special way that you need to order Amplify on the test requisition, and there's no extra cost associated with Amplify. Though it would have been possible to do the amplification as a reflex test on samples with low fetal fraction, we wanted all samples to benefit from the increased sensitivity of Amplify. And as we showed, this means that fetal fraction is amplified an average of 2.3-fold across all samples, and fetal fraction is amplified 3.9-fold in the traditionally difficult to call samples below 4%, where the signal increase is needed the most. We saw no samples in our validation study with a fetal fraction less than 4%, and we expect that more than 99.9% of Prequel samples will have a fetal fraction above 4%.
Great. Thanks, Dale. It looks like this next question is appropriate for you too. What fetal fraction will appear on the reports?
Because Amplify technology replaces the old NIPS method in our production lab, the fetal fraction that will appear on the report is calculated from this improved approach. Whereas for a validation study, it makes sense to run the samples on both platforms. Now that it's validated, we don't need to run the standard NIPS workflow anymore, so there will not be an old fetal fraction value on the report. Since the fetal fraction amplification happens before sequencing, it's really as if the sample came in the door with that higher fetal fraction, and the test performs as if the native fetal fraction were increased regardless of the underlying biology contributing to lower fetal fraction. To reiterate one of our key findings with Amplify, we've not yet observed a sample below 4% fetal fraction, which means that you can expect confident analytical results. Feel free to contact us at the email address on the screen, mwhwebinar@myriad.com, and we'd be happy to follow up to send you a sample report.
Excellent. Okay, next question. How do you know that Amplify works on all sample types, such as patients on blood thinners?
This is a great question and mostly boils down to how do you know that the blue triangle isn't in a different place for some samples? Because yeah, if the blue triangle we saw on a previous slide were elsewhere, then Amplify would not increase fetal fraction in the same way for all patients. So both the data in our study and data from multiple other studies in the literature all reinforce that fetal cell-free DNA is very reproducibly in the expected location of the expected length. And this is the location where Amplify acts. As for blood thinners, we don't have specific data on that group. However, our 2,400 samples in the verification and validation studies included more than 2,200 de-identified singleton samples randomly selected from our historical cohort. And we know that many of those patients were on blood thinners, but only 6 patients had fetal fraction that went down in our study, where we found that 99.8% of samples tested had higher fetal fraction with Amplify, and only 0.2% had a lower fetal fraction with Amplify. So, these observations alone suggest that Amplify increases fetal fraction even in patients on blood thinners.
Great. That's very helpful. And last question, it looks like we're going to have time for, this looks like it's for you, Dr. Goldberg. Should there be a concern about losing low fetal fraction as a clinical indicator?
Thanks, Susan. That's a great question. The primary aneuploidies associated with low fetal fraction are trisomy 13 and 18, and people who use NIPS platforms that fail low fetal fraction samples use that low fetal fraction measurement as a signal for increased risk of trisomy 13 and trisomy 18 samples. However, in our AMPLIFY validation, we showed that fetal signal from trisomy 13 and trisomy 18 increased dramatically. So those trisomy 13 and trisomy 18 samples now have higher fetal fraction and high confidence calls. Essentially, by using Prequel with AMPLIFY, you don't need to use the fetal fraction and test failures as an indirect proxy for T13 or T18. You instead get a confident and direct result.
Wonderful. Thank you both for answering those questions. That's all the time we have for questions today. I did see a few people ask if we're going to be sharing the slides from the presentation. And the answer is yes. We'll be sending out a recording of the webinar shortly after today. But if you have additional questions that you think of after the call, or you just generally like to get in touch with a local account executive or a regional medical specialist, feel free to send us an email at the email address you see on your screen here, mwhwebinar@myriad.com. So that will conclude today's session. Thank you very much for joining, and again, a big thank you to our speakers. Have a great rest of the day.